Hello and welcome. This is part of our very special series for GLI's celebration of pediatric and rare liver diseases, plural, month. Hopefully you have been enlightened and educated on some of the issues that mothers, fathers, families, infants, children's communities face when confronted with a diagnosis or a lack of diagnosis of a liver disease in pregnancy or for young children. But we would not be here, and our series would certainly not be complete without having a conversation with those dedicated clinicians, those fantastic researchers, physicians who have made care possible and have made the progress possible for women and families going through these trying situations. And I could not have better exemplars of providers on patient access in this area. Dr. Kathleen Schwarz is well known to anybody in this area, but I want to take a moment to just say how special she is to me and to GLI as one of our founding board members and one of the people who really put me on this path and made sure that if GLI did nothing else, we eventually found our way to create our Pediatric and Rare Liver Diseases Council and made sure that we never left the children out. So I want to thank Dr. Schwarz, who is pediatric. She's triple board certified, probably quadruple, quintuple by now, and is at Rady's Children in San Diego. And I have Dr. Laura Bonebrake, who I'm sure if I spent a decade with, I would have equal numbers of accolades and wonderful things to say about her. But we are just meeting. She's a medical advisor for ICP Care, who are our new best friends throughout this series. And I welcome you both.
Thank you. Thank you.
So Dr. Schwarz, start us off by just orienting us to some of the most prominent liver diseases that occur in pregnancy and infants, and why liver health should be such an important part of a healthy pregnancy and young lives.
So first of all, thank you so much, Donna, for having both Dr. Bonebrake, an obstetrician, because we speak at least similar languages, if not the same language.
Yes.
Have both a pediatrician and an obstetrician on the panel, and for all you're doing for patients with liver disease. So thank you. So I am going to just very briefly summarize the liver diseases in pregnancy, because I think Dr. Bonebrake is much better situated to expound on the details. But certainly I, as a pediatrician interested in liver disease of children, I think of the liver diseases of pregnancy, both from the standpoint of what might be transmitted to the fetus, and of course, hepatitis B and hepatitis C are the transmissible viruses that we worry about, although we also do worry about herpes. And then the metabolic liver diseases that we worry about during pregnancy, acute fatty liver of pregnancy, of course. And maybe you can expound a bit later, Dr. Bonebrake, but I was taught that women who have the HELP syndrome during pregnancy have an increased risk of having babies with fatty acid oxidation defects, which is one kind of metabolic liver disease. So those are that's a brief summary of maternal liver diseases that might be transmitted to the offspring. And then there should be a discussion at some point, Donna, on what Dr. Bonebrake thinks are the indications for management of the pregnant mother with hepatitis B and or hepatitis C, and how close the link should be between the obstetrician and the pediatrician. And I think that is in thinking about policy changes and improving outlook, making a closer link between OB GYN societies and pediatric societies when it comes to this mother fetus pair is really, really important.
That's absolutely our goal for this month and this effort. So often I hear, well, at least children don't get liver disease, and they do. And I hear, from mothers or who've just delivered, infants who are like, yeah, I was sort of itchy in pregnancy, but nobody said anything about it. Or women who are like, well, my baby was born a little jaundiced, and there just seems to be such a disconnect and such a gap on both sides that I'm very excited to bring both of you together and your societies together as well.
I do want to
forward.
Interrupt a bit, Donna, with all due respect, because almost all babies are born jaundiced. So because there is so-called physiologic jaundice, which is innocent. So I don't want people listening to this podcast to see their next newborn be jaundiced and instantly conclude that they're going to have serious liver disease, because most
how do you know the difference?
Babies are.
How do people know the difference? Then when it's just sort of something that happens, as of course, and will go away, and when they should pay attention and give light therapy and other things, how do you know the difference?
Well, I think there are two broad categories of difference. Healthy babies and sick babies. So the vast majority of babies, fortunately, are healthy. And the vast majority of these healthy babies have a few days of jaundice. And sometimes they even have to be put under bilirubin lights, kept in the nursery until the jaundice gets better. But that is so-called physiologic jaundice, and usually the baby goes home pretty soon. And the mother shouldn't worry. But jaundice that persists beyond, let's say, a week in those otherwise healthy babies is certainly an indication for the mother to go back to the pediatrician. Right now, the routine pediatric visits for newborns are at 2 months. That's too late.
Okay.
So parents need to be educated about asking for help about jaundice. Now, it's a different matter if the baby's sick, vomiting, fever, jaundice, diarrhea. And ironically, those babies usually get attention sooner. They have to.
Right.
But having mothers be more aware of the need to call for help with both persistent jaundice and also stool color, because the most serious liver disease in children is biliary atresia.
Right.
Biliary atresia accounts for about half of all pediatric liver transplants, because it's the most rapidly fibrosing liver disease in man. And ironically, the child looks well, except for being yellow. So often there is delay in referral to a medical center where there are pediatricians that know how to approach the problem. So we always teach.
I was going to say that was one of our very first conversations about,
Yes.
best practices in having stool cards like they do in Taiwan, and that you brought to Johns Hopkins, so that parents could identify chalky stools and be better able to, more quickly diagnose biliary atresia in their children, and so be empowered and be part of that process.
Right. And my trainee, who's now a very experienced pediatric hepatologist himself, Dr. Douglas Mogul, developed this iPhone Poop MD app so that parents.
I did not name it.
Take
I
a
did not
picture
name it. It
of
might have
their
been my
baby's
idea,
poop.
but I did not name it.
Right. And then the iPhone will tell them whether or not to worry about the color of the poop.
Wow.
That's right. So Dr. Bonebrake, let's let you into this conversation. So
Sure.
for the women that you work with, what are you seeing in terms of a baseline awareness of any need to be concerned about the liver, and how do you approach the issues with them?
Sure. Sure. Yeah. So I'm, as they said, an OB GYN. So I see pregnant women, and my kind of focus is on intrahepatic cholestasis of pregnancy, which is a liver condition that causes itching in pregnancy. But I would say as a whole, women approach pregnancy a lot with just looking at it as kind of less worry. I don't think women really think about a lot of times all the things that can happen in pregnancy. I think you go into a pregnancy and you think, oh, this is just kind of flows and goes, and we have this healthy baby at the end. And I think as an OB, obviously we see all of the deviations from that. And so I work with the charity ICP Care, that we work on raising awareness of just one specific liver disease in pregnancy, but it does kind of link to some of the other liver diseases because there is a risk if you have an underlying liver disease. Hepatitis C was mentioned, but some other ones of developing intrahepatic cholestasis of pregnancy. So I think I'm very aware of the liver disease, but I think as a whole, women out there in their pregnancies are not really aware of all the things that can affect them. And so we work really hard on educating women and educating providers on the different things that can occur. So,
are there genetic tests for ICP or risk factors? How would
yes,
one
yeah.
know?
Yes. So ICP itself, the main symptom that one knows is itching, which can be, a lot of people have itching in pregnancy, but the itching of intrahepatic cholestasis of pregnancy tends to be progressive and tends to be pretty significant. So women usually don't sleep. They say they can't sleep at night. They're up itching for hours and hours and hours. So that's the main symptom of ICP that we see. But as far as other things, there are risk factors. There are genetic risk factors for ICP. So it's been linked. Basically, ICP affects the flow of bile through the liver. So it has been linked to some of the different genes that are also linked to other gallbladder issues. We know that women with ICP have a 2 to 3 times more likely risk of needing to have their gallbladder removed in life, go on to have other liver issues later in life. Some of the autoimmune hepatitis is linked to it. We see a lot of women with actually alpha-1 antitrypsin deficiency that end up developing ICP. So it's kind of been interesting as the ICP literature and research has changed over the past few years. There's been a little bit more of a focus on these women after pregnancy. So a lot of times it was thought ICP, it's in your pregnancy. You have the risks involved in pregnancy, which I think we should mention. The main risk that people worry about is the risk of stillbirth, unfortunately. So it is something that women need to take seriously if they do have the itching. But later research has kind of linked it and shown that we probably need to be following these women lifelong, that at the end of their ICP pregnancy, we need to make sure that it goes in their history and make sure that their future physicians know about it, so that if years later they have elevations of liver functions, that they know, hey, I had this history of ICP, there might really be something going on. So I think that's been a great change and getting the word out about that it doesn't just end at pregnancy, and you guys need to make sure that you have lifelong, liver surveillance is kind of been a later focus of ours too. So
Can
So
women
Dr.
go on to,
Bonebrake,
go ahead.
yeah.
as I'm sure you're aware, there are a number of infantile and pediatric liver diseases where itching is a horrible problem.
Yes.
Yeah.
Yeah.
And there is this new class of drugs, ileal sodium bile acid transport inhibitors,
Mhm.
that interrupt the enterohepatic circulation of bile, that have been shown to be wonderfully effective in diseases with bile duct problems such as Alagille's syndrome. And now it's being tested in biliary atresia. And I just wanted to ask you, are those drugs possibly effective and safe for intrahepatic cholestasis of pregnancy?
So interestingly enough, there actually was a trial looking at one of those that actually ended early just because of the difficulty of enrolling pregnant women. So I do think their mechanism of action, and I heard that they seem to be very effective. We're not using them off label just because they're not FDA approved. But there was a trial, unfortunately. I mean, we can get into that a little bit too. Doing clinical trials on pregnant women is a whole kind of can of worms. And what we were running into, they weren't even in the placebo portion yet. They were still in where everyone was going to get the drug, kind of the dose dependent area of the trial. What we were running into, obviously, we have a really large support group that we are a part of. And just mentioning the drug, while people might have been interested, when you put something such as stillbirth on the table and then you tell someone that they're going to have the placebo, I mean, that's hard. I myself had 4 cholestasis pregnancies. And so I don't even know if as a physician, if you had said, there's a drug that, and we don't need to get into it, but there's a drug that sometimes works in some people, sometimes doesn't, or you can go in this trial and maybe get a placebo. I mean, that's hard for a woman. You're worried about your baby to say, sure, I'll do that. So I understand why the trial had to end early, but hopefully we're hopeful that maybe that is on the horizon, that someone else will pick that up and run with it. Because yeah, they do seem like they would be very safe in pregnancy. They're
I was going to say,
not absorbed. So yeah,
not absorbed, right?
Yeah, correct. Not absorbed. So the safety wasn't an issue. The safety for mom, and that was never an issue. All the people we talked about enrolling, it was really having to possibly be in that placebo arm. So that was the main.
Which is ironic because you don't have anything specific for the itching, do you?
So ursodeoxycholic acid is our main medication, but it I would say it works in some people. We see some people be a responder and some people are not. And in some people,
what is the medicine?
Ursodiol. Yeah. Yeah. So that's our only one that the medication that's out there. And in clinical trials, it hasn't been shown to prevent stillbirth. We think it has some benefits in helping decrease the aging of the placenta, helping replace kind of the more toxic bile acids. But unfortunately, it's not a drug that we can tell women, if you get on this, your baby's safe. And so that's what, as a community, we would really love to eventually have the ability to say, if you treat this, your baby will be safe. Because that's kind of what, obviously, it becomes a very mentally challenging journey through pregnancy when you have that worry every day. So,
and of course, Urso may be somewhat effective against COVID. That's the latest on Urso.
Oh, really? I hadn't heard. Oh, wow. Okay.
I believe it's New England Journal of Medicine. Right.
Which makes a little sense because we are, no real trials came out, but just in clinical practice, I saw some women had COVID-induced cholestasis. So it kind of makes sense that it might. Yeah. Interesting. So.
Things that we're learning. I think that creating a culture of clinical research in liver diseases, even in liver diseases of pregnancy, is very important to our understanding. Certainly as someone who is, met at my bedside with a drug that was still called FK506 at the time, and early Urso and things like that, and have been on FDA advisory committees, making sure that there is continued evolution in what we can offer patients is so important. And if patients don't participate in that, it's really just not possible. Although we're doing new things, I guess, with real world evidence and being able to capture cases in electronic medical records and sort of natural histories and other things. But I think that particularly when the standard of care is sort of, not a guarantee in and of itself, that the equipoise of being involved in clinical research is really important for women to consider to help not only themselves, but to the next woman and the next family.
Oh, definitely. Yes, definitely to be involved. We would love that there would be a guarantee eventually. So yes, yeah.
So, Dr. Bonebrake, you've been on both sides of this, both as mother and doctor, and I think it's important for because you can't explain pruritus, this itching that we're talking about. And we've done a whole cholestatic pruritus awareness, webinar. And it's not something you can explain to your doctor. And so can you sort of explain, but what is experiencing it brought to your care and how you approach women and families?
Oh, definitely. It's definitely changed my care. So my first cholestasis pregnancy, I was still in residency, and I actually kind of diagnosed myself. I said, I'm having some itching, and so we actually diagnosed myself. But no, it is not something you really can explain until you've had it. Some people are like, oh, I had some itching. Do I have this? Because they Google and they find us, which is great. I think bringing up anything to your physician is good. But no, the itching of a cholestatic liver disease is unlike anything else. Like people say, just stop itching, just use lotion, just do whatever. But really, like mine always started between my fingers, and I would sit here itching my fingers. I would rub my hands up and down the table. I would run my feet on the floor, just anything you could do. You sometimes even look sunburned from itching so much because you're just, so it's interesting. That's how I actually knew I had cholestasis. My last pregnancy, I was diagnosed at 4.5 weeks because I started itching between my fingers, and I said, this is cholestasis again. So I think, obviously that brings up the point of listening to your patient. We always advocate that very strongly in our
How about
group.
your ears? Did your ears itch?
My ears did not, luckily. So hey, yes, I might have lucked out there.
My palms were always itchy.
Your palms were, my palms. I would rub them on the side of the table. I was like, oh, so my palms, my feet. That's the classic of cholestasis, is that it's your hands and your feet. But most women do end up having kind of a full generalized pruritus with it. But no, it's very similar to the other cholestatic liver diseases. When we went to the liver meeting, we were next to the PBCers, and we had many conversations.
We bonded about the pruritus. Yeah.
We bonded over our itching. So we were like, oh, so, but luckily ours is only pregnancy for the most part. Some women do actually get cyclical itching with their periods afterwards. Not really well studied, an area that needs to probably be looked at a little more. But yeah, some women do have some lifelong itching with it, but definitely not as severe as some of the other cholestatic liver diseases. So
Dr. Schwarz, you started us on a direction talking about policy. So certainly, you've been a pioneer and helped bring NASPGHAN and SPGHAN to the table, to GLI. We're honored to have members of the AASLD SIG as well, many of whom trained under you at Hopkins and other places. From a policy standpoint, what can the medical societies and patient advocacy organizations be doing better together to ensure that children get the care that they need?
Well, I think having a closer union between the OB/GYN societies and pediatric societies, as well as pediatric GI, that is a very potentially powerful link, because, for example, right now, our Pediatric GI Society has developed what I think is a really wonderful teaching slide set on hepatitis C. And it has I believe, 120 slides that cover epidemiology and virology,
Mm-hmm.
symptoms and prevention and treatment and stigma.
Mm-hmm.
And so, and I had the honor of being the chair of that slide set, and I learned a lot from my colleagues.
Mm-hmm.
So NASPGHAN helped support that, and that slide set is now on and NASPGHAN, I should say, is the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition. It is about 2,000 plus members strong and has, I think, 98% of the pediatric gastroenterologists in North America.
Oh, wow.
And so that slide set is available to pediatric gastroenterologists for teaching about hepatitis C. But we think very strongly that we should link with general pediatricians, obstetricians, nurse practitioners, family practitioners, because the sad truth of the matter for hepatitis C is that the vast majority of the supposedly 3 million children in the world with hepatitis C don't even get diagnosed.
Right.
And then those high-risk clinics, the IV drug use clinics, where mothers have a much higher risk of having hepatitis C. Even in those high-risk clinics, it's been shown that not all mothers get screened for hepatitis C. And then if they do get screened, then there's much less chance that the babies would be screened. And then even if the babies, and you can't really screen for hepatitis C in a newborn, but there is a dramatic fall off. So to me, it's so tragic that this disease, hepatitis C, which is now highly
Curable,
as being missed in so many mother fetus units.
Well, it seems to me, we've been involved in conversations about hepatitis C elimination with Dr. Francis Collins and with John Ward, formerly from CDC, who's now leading the global elimination. We've also talked about hepatitis B, birth dose. It seems that this fragmentation of liver diseases is really an impediment in and of itself, because if you have a person, particularly if you have a pregnant woman and maybe your young children, the opportunity to screen for multiple liver diseases, viral or otherwise, and the opportunity to either vaccinate or treat for multiple liver diseases is too often lost. Do you believe that to be the case?
Absolutely.
Okay.
I mean, we definitely have data in hepatitis C, but that's also certainly true with hepatitis B. I have been the chairman of the pediatric subcommittee of the National Institute of Health Hepatitis B Research Network. And we have published, I think, the largest series of children in North America with hepatitis B. And there are definite ethnic risk factors. So half of these 400 children came from endemic countries where hepatitis C prevalence was at least 2%. And then all but 3% of the remainder were born to mothers in North America with hepatitis B, and the mothers came from endemic countries, and yet they weren't managed correctly during pregnancy. So there is, as you know, there is an opportunity to treat pregnant women with infected with hepatitis B with high viral loads, and yet, these mothers delivered babies who had hepatitis B, so the mothers weren't treated, and then the recommendations of the American Academy of Pediatrics, if you have a high-risk mother who has been shown to have hepatitis B, and you give the HBIG, the antibody to hepatitis B, as well as the first of a series of antigen-based vaccines within 12 hours of birth, then you have a much greater likelihood of helping that baby avoid this life-threatening liver disease.
Wow.
The,
things like this.
Sorry, I was going to say.
Yeah, Dr. Bonebrake, exactly. The synchrony between OB/GYN and pediatrics just really could be of such high value.
Yeah, and that's what I was curious in that study if a lot of those women were receiving care, and because I mean that's obviously something we see some women in some hepatitis C, for example, the IV drug use population. A lot of times they do come in for delivery, and it becomes a complex situation at that point. But I do think that is an area we could work very much better on at being combined. And I think not about liver diseases, but some other infectious diseases in pregnancy. As OBs, we're learning actually from the pediatricians. So the resurgence of some of the STDs and syphilis, like the pediatricians are actually driving it back to the OBs, I find. And I think that's been interesting. So I think it could work the same way because, as an OB, we're treating the whole pregnancy. And so it would be interesting to know if those women just weren't being fed to the correct care or what we can do to fix that. Yeah. So
good. Let's do that.
Yeah. It was very interesting when we attended the liver meeting. Being a pregnancy organization I think that was the first step. It's like, okay, you can have pregnancy and liver stuff. So yeah.
Exactly. That's exactly what we've been trying to tell everyone this month. I wanted to make sure that we had the opportunity to address any barriers to care, any structural barriers to care, because clearly you all have it, on lock from the clinical side. But are there any barriers, whether insurance or others, to the type of care that you'd like to give in pregnancy, and the type of care that you'd like to give to children with liver disease, Dr. Schwarz? I'll talk to Dr. Bonebrake first about any barriers.
Yeah, definitely. I mean, so the big topics that have been in the news lately, you talk about maternity care, especially rural maternity care has changed. If you look at it, a woman living in rural America might have up to a 30 to 60 minute drive to get to obstetric care. And there's actually been shown an increase in maternal mortality and morbidity for women living in rural America. So I think access to care, both location and then also I would say on the insurance side of things, one of the big things we run into is in-network, out-of-network. I mean, I think that needs to really be addressed. Cholestasis is obviously this is a conversation about rare liver diseases, but an OB might see it once every 5 years, might have a case. So you're like, oh, I need to read up again. What do I do? So a lot of these women end up needing to see a specialist, a maternal fetal medicine specialist, and there might not be one close by. It might be a 2-hour drive to see them. And, so that's kind of one of the things. And then if you even can see one, are they in network? Are they going to be covered? And then the other thing you think about with cholestasis, and I actually ran into in one of my pregnancies, is these babies have to be delivered early depending on level. So a lot of times you're looking at a premature infant just to prevent that risk of stillbirth. And you're also looking at 2 to 3 times more likely that these babies go to the neonatal ICU just because of respiratory distress. They think the bile acids actually affect the surfactant production in the lungs. And so these babies are more likely to need a NICU. So these moms in the middle of this anxious pregnancy are trying to figure out where can they go both geographically? Is it going to be covered? I actually had one time when my insurance only covered one hospital without a NICU, and I knew I was delivering at 35 weeks. And I was like, what do I do here? So I think, those networks need to be expanded, that a mom doesn't need to be worrying about at the end of this hugely anxiety-driven pregnancy, am I going to end up with this bill for a $250,000 NICU stay? I mean, I think that needs to be opened up and more transparency with these women just need care. They don't need to be worrying about, is it covered? Is it not covered? Would be kind of what we see. So.
Oh, absolutely. Even within some urban environments, we had here in Washington, D.C., several hospitals that were responsible for majority of births, close
Yeah.
in rapid succession. And so the reconstructing of the other hospital resources, even within the nation's capital, to be able to deliver all the babies, safely, not the normal load, and then have access to NICUs appropriately, can happen. And so I think this, crisis in access in maternal care, as we are looking at having more births, potentially in several states, that we need to think about, not just the care stopping at the birth, but
yes.
going beyond. And so, Dr. Schwarz, when you think about the support that women get either from their employers or their insurers for the 6 weeks beyond pregnancy and the early childhood years, are people getting what they need, or are there things that we could do better to ensure that the children are healthy and that the mom's next pregnancy is healthy? Can there be better continuity of insurance coverage or other things, to make sure we have healthier families?
Well, I think healthcare in America is broken, so the answer is a resounding yes.
Understatement of the year, yes.
Yeah. and it's also interesting that there's such wide disparity among states.
Mm-hmm.
And I found that out in the hepatitis C arena, because when we put this slide set together, we had Daniel Lung from Texas Children's,
Mm-hmm.
and he was supposed to write about the treatment part of the
Mm-hmm.
hepatitis C slide set. And in Texas, no surprise, I'm sure, the pediatricians and pediatric gastroenterologists and parents, of course, face huge battles in getting the hepatitis C drugs paid for.
Mm-hmm.
So, and I'm sure Texas is not the only state where that happens. And that, to me, is such a tragedy on so many levels. But we have definite documentation that eradication of hepatitis C virus in children, and the drugs are now approved for 3-year-olds and up, is highly cost effective.
Right.
Because dramatically reduces the incidence of liver disease, liver cancer, liver transplant. So it's so ironic that the policymakers don't take the data into consideration.
Right. And the data is there, and it's very clear. And I think also when we consider the number of mothers and children who are covered under federal programs, Medicaid and SCHIP, particularly, it really could have a larger, coordinated federal, solution. But we see, large numbers, in fact, the majority of mothers and children who are even identified with viral hepatitis, with hepatitis C, with liver diseases that are not treated. And so
Right.
Part of this is just to draw attention. There's awareness, but there's also a value and an impetus to action that we must compel, to take what we know and what we do have, and actually apply it, give it to people. So that's what we'll work on.
I know that this session is devoted to rare liver diseases.
Yes.
But yesterday I was in an editorial board meeting
Mm-hmm.
of a pediatric journal where the editors were pumping us for ideas about topics to discuss in the coming year.
Mm-hmm.
And of course, I talked about viral hepatitis in infants and children, but the two hot topics other than COVID for pediatricians in on the planet are obesity, because there's a new series of obesity guidelines. And of course, fatty liver disease is the most common liver disease in both children and adults.
Yes.
And mental health crisis.
Yes.
And because of COVID, of course, we've had a huge increase in mental health crisis, a decrease in mental health providers. And I bring this up even though we're talking about rare diseases, because, if we have a mother of a child with a rare liver disease, or the mother has a rare liver disease, and then she has to battle depression and anxiety and stigma, that whole area of both obesity management and mental health management impacts both common liver diseases in mothers and children and rare diseases. So
I'm so glad that you brought that up, because that's exactly why when we were making the strategic decision of how to where to locate pediatric NASH in particular, and we decided to design it as the Pediatric and Rare Liver Disease Council, because we've determined the sensitivities that would be needed for a pediatric version, even of a common disease, still needed the sensitivity and the relationships that we would need to build with OBs and with pediatricians. And I'm so grateful that AAP has those new guidelines and is giving that attention. Needs to be different. Even our, Beyond the Biopsy campaign takes on a special significance when we're talking about children. Who wants their child, to go through biopsies if you don't have to? If we can evolve non-invasive diagnostics faster to give us, the information that's needed for care. So I think that that's certainly fair game for me to discuss anything pediatric liver disease as part of this series, and how to give, parents and pregnant people, which is the theme for the whole month, better care of whatever liver disease they have, and on the road to global liver health.
And I think that's something that, ACOG, our society, our guidelines, is pushing a lot more for this fourth trimester. I think as OBs, we work with a woman, we get them through the pregnancy, and we almost think, yay, we did it, here we are. But this fourth trimester really needs to be addressed. And that's been a big push of ACOGs and mental health. When you look at the maternal mortality committees, I'm in Missouri, and their report that they just released from their latest mortality committee, in that mental health was one of the highest risks to a maternal life. So that needs to definitely be something that's addressed, not just on the liver disease side, but we do have these women with cholestasis who do probably tend to be more the postpartum depression. You have a baby that's in the NICU, you had this hard pregnancy, it's there. Right. And as an OB, it's very difficult to get these women into care. There's just either not the resources there. It's where do we send these women? Oh, I don't know. Do we consult social work? Where can we send these? Where can her insurance cover again? But then also just looking at the whole social structure, some of these higher risk women who are going to be your hepatitis C, your patients with that, do they have the transportation to get there? Are they going to come to their postpartum visit? And how do we tackle that just as a whole, I think is a big issue. So,
and I think another area for policy development is how do we deliver healthcare? And I was just thinking, I had the honor of being a visiting professor in Cairo recently. And of course, Egypt has the highest hepatitis C rate in the world. So one of the presentations I heard when I gave my presentation was so interesting. That was point of care. So the Egyptians, who have, of course, we think we have problems with rural America, little desert village where there's a high prevalence of hepatitis C. So what the Egyptian government has done is to fund healthcare units for point of care testing and treatment initiation with one visit. So it's just fabulous because, they take their Jeeps out to the little village and they have a PCR that test that can test the viremia rapidly, or I guess maybe they do antibody and then PCR for the virus itself. And if the patient is positive, then there's a doctor on that Jeep that knows how to treat hepatitis C. So they start the treatment and then they come back 12 weeks later and retest, and most patients have responded. So that, and it's so effective, so cost effective.
Right.
So, but we need government support to do that in America. We can't even get school cards in maternity.
We'll work on that. We're working on those. I was, reintroducing that concept to the staff over the course of this work, and they're committed again, and so more to come on that. But I think that the bringing care to people. Certainly so important when you are juggling pregnancy and a family and a job and other children, and so we can do better to bring care, whole person, whole family care to people, and so that is certainly our commitment here at GLI, and thank you for helping us do that.
And I love your use of the fourth trimester, Dr. Bonebrake. I've never heard that term.
It came from ACOG, so I won't claim it, but ACOG has started, so the fourth trimester, because it really is.
Yes.
I once had a doctor say, see this umbilical cord on the ultrasound, when I cut that, like, I'm done with your baby, but not really truly, right? Like, we still need to be concerned about the whole family.
Well, my favorite television series is called The Midwife. I just love it.
Yeah.
Oh yeah, there is an ICP episode. They had a one of the actresses in there had actually cholestasis, so she did there's a set of ICP episodes. So
maybe we can talk about having her afterwards, and
yeah. Oh yeah, she's been
great.
yes. Yeah. So yes. Yeah. So
all right. More to come, more than we can hold in one short month.
Yes.
So
I'm
excited to work with you all for the rest of the year and for the rest of the time for the Pediatric and Rare Liver Diseases Council. Thank you so much for this conversation today.
Thank you for focusing on mothers and children on the fourth trimester.
Yeah.